Hello, everybody. My name's Ed Pavlik. I'm in Lexington, Kentucky on a coolish day. Rain's coming down. And my colleague today is,
Frank Lawton from London, UK, and you can probably see by the reflection in my glasses that the sun is shining. We're expecting a lot of very warm weather in the next few days. And considering it's a public holiday, that's very, very unusual. It always rains on British public holiday weekends. So perhaps this is global warming. Excuse me.
well, our public holiday is Memorial Day. What is your public holiday?
I've no idea. It's May Day, probably. It's I've no idea. The late bank holiday. It used to be Whit, I think, which was a religious festival. But they keep moving them around. I don't really I know Christmas and New Year and Easter. I can do those, but the others are three or four that are just sort of named after a day, as far as I know. I don't really know what they're for.
Okay, well, let's get started. Today we're going to consider a question that is, do patients with symptoms and with severe ovarian cancers get diagnosed more quickly but have poorer outcomes? The answer to this question is approached in a paper titled Diagnostic Timing and Ovarian Cancer Survival. Um, this paper was published in JAMA Network Open pretty recently. So, what we're all about in terms of this paper is looking at this particular table that I'm going to call up, and that simply says that if we look at all patients in the study that had uh, uh, symptoms, then we can say what happens if they had symptoms for a short time or for a long time. The symptoms interval for lasting in this particular study went from a median of about 33 days out to 150 days, and they fell into four quartiles. And the end result was survival was examined for people in each one of those quartiles. So in the shortest quartile, people had the women had the shortest survival, and for the longest quartile, there's the longest time that they had symptoms before treatment. They also had the shortest survival. The Goldilocks factor was those in the middle and the second and third quartiles, where their survival was better. Now, this can be validated also by the hazard ratios. So the hazard ratio was for death was above one in both the first quartile and the fourth quartile. So how could this happen? And what does this mean? Well, I think the main thing it means is the symptoms are the most obvious in people, in some people, and those people are going to get treatment quickly, and they'll fall into the shortest quartile, quartile one. And then there'll be people who have advanced disease, but only have mild symptoms or one of five or six symptoms. And those will fall into perhaps a diagnostic enigma, so that it'll take a little longer before they get surgery. But if they wait too long, the disease has a chance to develop, and that's in quartile four. And bang, there you have it. Survival is as bad as it is, or is as poor as it is in quartile one, the shortest period with symptoms. The evidence that all this is based upon are Kaplan-Meier's, and you can tell if you look at the bottom here, those the shortest interval in green and those with the longest interval of symptoms in black have the poorest survival, and the third and fourth quartiles up here have much better survivals. So what can this mean? Well, it means probably that the most aggressive cancers are diagnosed quickly because their symptoms are more apparent, but because they're the most aggressive, they have the poorest prognosis. And then if you allow the disease through diagnostic delays to progress, eventually the longest time it takes will result in the ovarian cancers they're having a chance to progress. In the paper, they're very clear that that different symptoms have a role. And that was, of course, something that I had some trouble sorting out. Um, uh, in a sense, it wasn't really clear if one, two, three, four, five, or six symptoms was any worse than one or two. But it was clear qualitatively that certain symptoms were poorer than others. In the end, I think their story makes sense. I will point out that it's based upon a relatively small number of people, 2,300 people. Um, and also, median age was 71, which is a little bit on the older side, ranging on the IRQs from 64 to 78. So, in a sense, there may be sort of a a a limitation to the study based upon how much chance they really did get to survive, how frail they were, and that type of thing. Frank, what do you think?
Yes, I never heard of this thing called wait time paradox, but clearly it's something that's just gone over my head, and I can understand the logic behind it. And I can see how the curves separate. It's my main concern is that the authors have almost, well, consider that it's the wait time paradox that is the most important of the prognostic factors. And they list in one of the tables, I think one of the tables that you can see within the article rather than hidden in the supplement somewhere, that there are quite a number of statistically relevant things that they've recorded, such as age at diagnosis, the SEER stage, which I assume is because it's from SEER, must be of good quality. The Kerman, they look at Kerman pathology, which, if you read the paper, actually just talks about type 1 and type 2 ovarian cancers. Um, the intervals between presenting symptoms. And one of the things that I think is most concerning is that because it is, you ask the patient, when did your symptoms start? That's the link. How long had the patient, before they appeared to their doctor, how long had they had the particular symptoms? So had some women with not very with quite minor symptoms actually put off the consultation, in which case, which group do they appear in? Some women who may have very major symptoms might not want to visit a doctor, might not want surgery. Um, we don't, there's nothing in the paper about subsequent treatment. So whether or not once the patient had been diagnosed, whether certain patients, perhaps in a younger group or an older group or whatever, had different chemotherapy or PARP inhibitors or whatever else over the time period. We don't know how many patients achieved R0 surgery at debulking surgery, and we don't know how many patients refused treatment before they ended up in one of the groups or not. So I think it's very vague, unfortunately. The concept I can understand, but I'm not sure that there's enough data in here or enough data in the presentation to say it's the wait time paradox that is important here. There are so many other factors that they've ignored or just haven't presented, which affect the prognosis in epithelial ovarian cancer, and they don't appear in the paper. At least I can't find them.
No, I agree. I think the table that you were referring to, I can pull up real quickly and just show it. Um, and as you can see, for instance, on localized and regional disease, uh, it is quite possible that rather than the diagnostic period being the weighty variable, it was really the type of cancer being just localized at diagnosis. And of course, that would make it a more difficult diagnosis. Um, and, I think to a certain extent, by throwing in undifferentiated with low grade and mucinous, um, you've really given the experiment too many variables that can cause the differences themselves. So, I don't, say I don't believe what's happening here. It just wasn't the clearest demonstration of what they ended up with.
Yeah. Yes, I think that's the good point. They seem to have almost excluded all of the other prognostic variables in order to emphasize this idea of the wait time paradox. I'm sure it exists, and I think it's a very reasonable idea. But you can't ignore all of the other prognostic factors in something like this. There are so many prognostic factors as well that the numbers are going to get pretty small as well. So they've obviously done it for a reason. Perhaps it was to get the paper published, but I think that it's going to be repeated, isn't it? There's no doubt that this is. I think this is quite an interesting concept, and I think other institutions will try and determine whether or not they can reproduce the data. If they do, I hope that they take everything else into consideration and don't just focus on this this wait time paradox.
Right, and we may be again dealing with the problem where um, the presentation of data is very sophisticated, done by very learned people who have been trained in statistics or epidemiology, and for some reason have not gotten enough guidance from people who have a clear clinical picture of what these diseases are all about. I don't know that that is or is not the case, but it's a possibility. It is impressive how they've sifted through the diseases, the cases, um, and it's that's very meritorious. But on the other hand, I think they're missing a few things in terms of what it all means.
Yes, I did find that this. I know that you have to reproduce, or at least you have to explain to your readership about the statistics and the analysis that we use. But a lot of it I really didn't understand, and the words that they used. And let's face it, this paper is going to be read by clinicians, not by epidemiologists or statisticians. And I think it went over my head a little bit. I started to get a bit bleary-eyed looking, and some of the words that they used, I didn't really understand what they meant. And that's always a bad thing, because I think if it puts you off reading the paper, you may actually miss something that's very, very important.
Yeah, you had to hunt a little bit for
Yeah.
coming to
Oh,
the
yes.
conclusions. Well, we've done it again, Frank. I've enjoyed our time together, and we plan to do it again next month. Okay.
We will indeed. Okay. See you, Ed.
Okay. Bye bye.
Bye bye now.